Hello and welcome. In today's session, we'll be discussing opioid use disorder, both its diagnosis and management. My name is Noah Cooperstein. I'm a board-certified family medicine physician. I work as a full-time faculty member at St. Louis University's Southwest Illinois Family Medicine Residency Program. I practice a mix of inpatient and outpatient medicine, and I treat patients with both acute and chronic pain, often in the setting of overlapping conditions of opioid use disorder, substance use disorder, and HIV. I have no relevant disclosures. We have three primary learning objectives for today's session. One is to implement an effective, patient-centered taper of opioid medications for patients who are already on high doses or higher than recommended doses of opioids. Two, to recognize and treat opioid use disorder. And three, to identify instances where we would need to refer a patient to either a pain management specialist or an addiction medicine specialist. Today's session draws heavily on the 2022 CDC Clinical Practice Guideline for prescribing opioids for pain. This guideline is certainly cognizant of the opioid epidemic, but it presents a balanced and thoughtful perspective on the safe use of opioid pain medications, and it's not overly prescriptive or rigid, leaving room for discernment and clinical reasoning. It acknowledges that opioids, when used responsibly, can be part of a comprehensive plan of pain management for both acute and chronic pain. Additionally, the guideline provides resources on the identification and management of opioid use disorder in the setting of chronic pain requiring opioid pain medications, and that's largely what we'll be discussing today. Let's start by considering a case, but rather than me giving you a case, I'd like you to take just a moment to think of a patient who you've seen recently who is on long-term opioids. Maybe they are on more than 50 MME a day, that is to say more than 50 morphine milligram equivalents. Whatever dose they are on, maybe the patient perceives no benefit or a very limited benefit from the medication, or maybe they find the side effects intolerable. Perhaps the patient states that they would like to discontinue opioid pain medications eventually. Whatever the case you're thinking of, if you're considering an opioid taper, where do you begin? Well, the first key point here is that you more than likely need to begin with a taper, and unless there are indications of a life-threatening issue such as an impending overdose, that is to say the patient's confused or sedated, they have slurred speech, or evidence of respiratory depression, opioid therapy should not be abruptly discontinued, and clinicians should not rapidly reduce opioid dosages from higher dosages. Tapers take time. One of the cornerstones of a successful taper is patient agreement and interest in completing a taper. There will be instances, however, where clinicians perceive the need for a taper and patients may not agree. If you are not able to arrive at a consensus with your patient, acknowledge that. Acknowledge the discordance and express empathy, and do your best to find a way to continue treating the patient. A patient's reluctance to agree to a taper should not be grounds for dismissing the patient from your practice. This should be treated really as an opportunity to address patient safety and potentially avoid a life-threatening opioid overdose. But in most cases, patients will at least be willing to discuss a taper. And in these cases, collaborate with your patient on the tapering plan, including decisions about how quickly to taper and if there will be any pauses in the taper along the way. When tapering a patient on opioids, follow up with them frequently, probably at least monthly. Leverage your entire clinical team during the taper, including nurses, pharmacists, and behavioral health professionals. Stay in touch with the patient through telephone, telehealth, and face-to-face visits. Again, tapering takes time. When tapering, go slowly enough to minimize or avoid symptoms and signs of opioid withdrawal. These include anxiety, insomnia, abdominal pain, vomiting, diarrhea, diaphoresis, tremor, and tachycardia. Longer duration of opioid therapy requires a longer taper. For patients who have taken opioids for long-term, for example, greater than a year, tapers can be completed over months or sometimes even years, depending on the initial opioid dosage, and this should really be individualized based on the patient's goals and concerns. And again, patient buy-in is key. Here you can see how symptoms of opioid withdrawal evolve and develop over a 3-day period, starting with lacrimation and rhinorrhea, diaphoresis and yawning, and developing into more GI symptoms and potentially some metabolic derangements like dehydration, hyperglycemia, and even hypotension if not managed appropriately. Both the clinical opioid withdrawal scale, the COWS, and the subjective opioid withdrawal scale, the SOWS, can be used to assess the severity of opioid withdrawal symptoms. Both are Likert-style questionnaires assessing symptoms such as pulse rate, gastrointestinal upset, tremor, anxiety, irritability, pupil size, and other symptoms. Frequently, and especially in the hospital, the clinical opioid withdrawal scale is administered by nursing staff. This is an absolutely acceptable practice as long as the nursing staff is familiar with the COWS scale and has used it in the past. As a clinician, if you are monitoring a patient for opioid withdrawal while in the hospital using the COWS scale, I would recommend scoring the patient personally once per shift or once per day, just to corroborate the scores coming from nursing. This can happen sort of by and by with the patient assessment. It can also provide an opportunity to train new nursing staff who are maybe less familiar with the use of the COWS. A few considerations when tapering opioids. When patients have been taking opioids for greater than a year, tapers of approximately 10% a month or slower are likely to be better tolerated than more rapid tapers. If a patient is struggling to tolerate a taper, make sure that the patient's non-opioid treatments are optimized and work with the patient and other clinical support staff to address behavioral distress. If the patient is having clinically significant opioid withdrawal symptoms, that may signal a need to further slow the taper. There may also be instances where a taper needs to be paused and then restarted again when the patient is ready, and you might have to restart at a slower rate than what was previously planned. Finally, as patients reach lower doses of opioids, there may be a need to slow the taper even further. That is to say that not all tapers will be perfectly linear reductions. There are both opioid and non-opioid pharmacologic options for palliation of opioid withdrawal symptoms. These include opioid agonist therapy such as buprenorphine and naloxone, known as Suboxone, and methadone. There are also alpha-2 adrenergic agonists, including clonidine and tizanidine, and adjuvant symptom-specific therapies such as gabapentin, loperamide, hydroxyzine, ondansetron, and meloxicam. Here we see some of the schedules for tapering opioids. The slowest taper, which happens over years, we're talking about a 2 to 10% reduction every 4 to 8 weeks with pauses as needed. This is something to consider with patients who have been on high doses for a long time. A more common taper regimen would be reducing by 5 to 20% every 4 weeks, with pauses in taper as needed. The next faster taper would be a 10 to 20% reduction every week. The final rapid taper would be a reduction of 20 to 50% of the first dose, then reduced by 10 to 20% every day. This rapid taper is something to consider if the patient has only been on scheduled opioids for 5 to 7 days, but it is not recommended in cases where patients have been on chronic or scheduled opioids for any amount of time exceeding 2 to 3 weeks. Whatever taper schedule you choose, the best taper is the one that the patient is able to complete. The goals of tapering should be determined together with the patient, and they're not always going to be the same. Some patients might wish to achieve a complete discontinuation of opioid pain medications, while others, the agreement may be to reach a reduced dose at which functional benefits outweigh the risks. If the goal is to ultimately stop opioids with the taper, then after the smallest available dose is reached, the interval between doses can be extended and opioids can be stopped when taken less frequently than once a day. Tapering is not without risk. Aside from withdrawal symptoms, there is actually an increased risk of overdose should a patient taper down to a lower dose of opioid and then suddenly return to a higher dose or their previous dose of opioid. Patients on an opioid taper should be educated about opioid tolerance, and the clinician should discuss the risks of an opioid overdose should they return to their original dose abruptly. Moreover, these patients should be offered a naloxone prescription. As a patient tapers, remain alert to signs of anxiety, depression, and of opioid misuse or opioid use disorder. These might be revealed by the opioid taper. If you identify any of these comorbidities, initiate treatment for them, and this includes treatment for opioid use disorder. While anybody can develop opioid use disorder, there are certain risk factors to consider. These include a history of substance use disorder, that can be personal or in the family, current mental health disorder, that can include depression or anxiety, age less than 45 years old, Caucasian ethnicity, significant history of legal problems or incarceration, recent release from incarceration, or recent completion of inpatient treatment for addiction. Opioid use disorder is disruptive to people's lives in myriad ways, but the biggest risk here is opioid overdose and death. In fact, in the United States, since 1999, we've seen more than 500,000 deaths from opioid overdose. While some patients will openly report active substance use disorder or opioid use disorder, and other patients will present with signs and symptoms of opioid use disorder, And in fact, the patients themselves may not necessarily be aware that they have an issue with the use of opioids. As is the case for any screening test, screening for opioid use disorder allows us to evaluate the entire population, picking up patients who need further evaluation or treatment. Screening for substance use disorder and opioid use disorder is, of course, a topic unto itself. The SBIRT model, which stands for Screening, Brief Intervention, Referral to Treatment, does provide a good structure to organize the role of the various other screening options available. The conundrum with screening is always what to do if the patient screens positive, and the SBIRT model offers those next steps. While no means a comprehensive list, a few of the screening tools to consider include the Drug Abuse Screening Test, or DAST-10, Alcohol, Smoking, and Substance Involvement Screening Test, ASSIST, Car, Relax, Alone, Forget, Friends, Trouble Screening Test, CRAFT, that's useful for adolescents, and Screening to Brief Intervention, S2BI. But there are many other options available, and those can all be fit into the SBIRT model. Whichever screening test fits best in your practice and to your patient population, that can be integrated into the screening component of the SBIRT model. If a patient does screen positive, your next step is to offer brief intervention. This typically consists of some motivational discussion that involves outlining the risks and the consequences of a substance use or opioid use disorder. A key component in this brief intervention is not only creating the motivation to change, but empowering the patient to feel that they are able to change. If a patient not only screens positive, but has signs of severe use or dependence, or is engaging in dangerous or risky behavior, if there's concern that the patient is at imminent risk of an opioid overdose, that's not just a cue for a brief intervention or brief treatment, but that should prompt either referral to treatment or initiation of treatment for opioid use disorder. Just a friendly reminder that screening is not diagnosis. Screening tests, of course, are going to have a high sensitivity but a low specificity. The diagnostic process is going to add that specificity. The previous edition of the Diagnostic and Statistical Manual of Mental Disorders, the 4th edition of the DSM, referred to opioid abuse or opioid dependence. The DSM-5 updated the name of the diagnosis to opioid use disorder, and that's the name we've been using here. The DSM-5 defines opioid use disorder as a problematic pattern of opioid use leading to clinically significant impairment or distress. The DSM-5 diagnostic criteria for opioid use disorder will be familiar to any clinician with any experience with addiction. It includes the all too common themes of an inability to control use, cravings, disruption of the patient's life, patient being in danger because of their use, and finally, tolerance and withdrawal. There are a total of 11 diagnostic criteria on the list. Each positive answer to one of the criteria is scored with a point. Patients scoring less than 2 have no symptoms or no disorder. 2 to 3 is mild, 4 to 5 moderate, and greater than 6 severe. It is, however, important to note that patients who are taking opioids solely under appropriate medical supervision are not subject to criteria 10, which is tolerance, and criteria 11, which is withdrawal. Understanding the neurobiology of opioid use disorder allows us as clinicians to understand the magnitude and severity of the issue for our patients and what it actually means for them to be addicted to opioids. The pathogenesis of opioid use disorder involves a cycle of addiction involving a few key brain structures. These are the basal ganglia, which is actually comprised of several structures and is overall responsible for coordinated movements. One of its substructures, the nucleus accumbens, is in charge of motivation and the overarching reward experience. The dorsal striatum is related to formation of habits and developing routine behaviors. The extended amygdala is responsible for the stress response and partially influences the hypothalamus as well. This is where fight or flight comes from and is the seat of experience of unease, anxiety, and irritability. That is to say, a lot of negative emotions. And finally, the prefrontal cortex controls complex cognitive processes, commonly known as executive function. It organizes thoughts and activities, tasks, and decision-making, and has influence over impulse control and emotional control. The cycle of addiction involves 3 stages: binge and intoxication, then withdrawal and negative affect, and finally preoccupation and anticipation, prior to once again engaging in binge behavior. In the binge phase, the ventral tegmental area, VTA, regulates reward, learning, and memory via dopamine release. The introduction of opioids into the system triggers a powerful dopaminergic reaction from the VTA. The VTA projects to the nucleus accumbens in the basal ganglia, and is the nucleus accumbens which creates the reward experience. During the reward deficit phase, as opioids are metabolized or withdrawn, there is a reduction in the reward system mediated by the VTA and the nucleus accumbens. The VTA transitions to signaling the limbic system through its non-dopaminergic projections. VTA signals to the central nucleus of the amygdala and the bed nucleus of the striata terminalis result in the release of stress neurotransmitter, namely corticotropin-releasing hormone factor and dynorphin. These neurotransmitters remove the inhibition of norepinephrine and prompt a subsequent increase in sympathetic tone. Ultimate result of all of this is an anxious, irritated, negative physical and emotional state. In the preoccupation phase, increased sympathetic tone and additional inputs from the limbic system disrupt the executive function of the prefrontal cortex. The usual risk-benefit processing of the prefrontal cortex is hijacked by cravings and habitual response. The lower levels of the brain literally take over higher levels of reasoning. As the end result, the patient seeks out and uses opioids. This is not a question of willpower. This is an alteration of the brain's functions after exposure to a concentrated substance that does not occur on its own in nature. This is a physiologic condition. The take-home message from the neurobiology of opioid use disorder is that it is a chronic, treatable disease from which people can recover and continue to lead healthy lives. But the stigma associated with it can reduce the willingness of people with opioid use disorder to seek treatment. As clinicians, it is paramount that we recognize and validate the physiologic basis for opioid use disorder. It is not a question of a person's character, and we need to be on the forefront of removing this stigma. If a patient screens positive for opioid use disorder or just meets the diagnostic criteria for opioid use disorder, discuss this concern or diagnosis with the patient in an open and non-judgmental manner, in the exact same way that you would discuss any other physiologic condition such as diabetes or hypertension. This is a key step to removing that stigma and hopefully creating a space where the patient feels that they can openly discuss their own concerns and their own experience. Avoid stigmatizing language when discussing opioid use disorder with patients. Avoid words like addict, junkie, drug user, or druggie, relapse. And don't talk about being clean. When discussing urine toxicology, don't call it dirty urine or a failed urine screen. And of course, as we've been discussing, avoid terminology around being weak or not having willpower. And while this is important for clinicians, often it's the patients who are the hardest on themselves in the language they use. And so I would recommend correcting them and discouraging them from talking about themselves in this way as well. A way to help avoid stigmatizing language is to use the person with or person who phrasing. For example, a person with opioid use disorder or a person who uses IV drugs. And when talking about medical management, you can refer to pharmacotherapy. Given the profound physiologic basis for opioid use disorder that we've been discussing, it's important to know that if you do diagnose a patient with opioid use disorder, they need to be referred to treatment or started on treatment with medications specifically for opioid use disorder. And hopefully this goes without saying, but it is in the guidelines, that you should never, under any circumstances, dismiss a patient from your practice because of opioid use disorder. This is dangerous to the patient, and it's a missed opportunity to treat, again, a physiologic condition for which medications are available. There's lots of evidence for medication treatment of opioid use disorder, but maybe the most telling is that there's an association between starting medical treatment and a reduced risk of death and overdose. Identification of opioid use disorder represents an opportunity for a clinician to initiate potentially life-saving interventions. This is a key time to collaborate with the patient regarding their safety and to increase their likelihood of successful treatment. This is the old mantra in addiction medicine of really meeting patients where they are. While not all clinicians will treat opioid use disorder, any clinician prescribing opioids should, at a minimum, identify treatment resources for opioid use disorder in the community and work to establish a referral network that has options for patients that span levels of care and enable rapid collaboration and referral when needed. For any patient diagnosed with opioid use disorder, clinicians should offer to arrange treatment with evidence-based medications. Detoxification on its own without medications for opioid use disorder is not recommended, and in fact can be dangerous and has an increased risk of resuming drug use, overdose, and death. Again, this is not a question of willpower, it's a physiologic condition that requires medical management. So what are the pharmacologic options for treating opioid use disorder? Well, FDA-approved medications indicated for the treatment of opioid use disorder include buprenorphine, which is a partial agonist opioid, methadone, which is a full agonist opioid, and naltrexone, which is an opioid antagonist. These FDA-approved medications come in a variety of formulations. Buprenorphine is available as sublingual tablets, as an extended-release injection, or even as an implant. Methadone comes in tablets or an oral liquid. Naltrexone is available in tablets or an extended-release injectable. And then buprenorphine in combination with naloxone, commonly known as Suboxone, is available in a sublingual film or a buccal film, and also in a sublingual tablet. Buprenorphine for treatment of opioid use disorder is usually combined with naloxone in a sublingual or buccal film or tablet, commonly known as Suboxone. This is meant to reduce the potential for misuse of buprenorphine if it's manipulated and injected. Naloxone is poorly absorbed orally. However, if it's injected, it will trigger a powerful opioid withdrawal response. Now, while I've presented these different options for medical management on the same slide, they are not all the same. Partial agonist opioids, full agonist opioids, and opioid antagonist treatments should not be framed as equal options for opioid use disorder. Partial and full agonist opioid treatments are better, and they have better evidence to support their outcomes. They do not require abstinence prior to initiation. They have less challenges with initiation in general, and they're much more widely used than opioid antagonist treatments. Now, there have been some changes in the prescriber landscape regarding who can prescribe buprenorphine for opioid use disorder. In April of 2021, the DEA changed its requirements for prescribing buprenorphine. To prescribe buprenorphine for opioid use disorder for up to 30 patients in an office-based setting, clinicians can forego or choose to undertake training, but must still receive a waiver from the Substance Abuse and Mental Health Services Administration. However, while the training is now optional, if you're not familiar with the use of buprenorphine already, it's highly recommended that you complete the Substance Abuse and Health Administration Services training or a comparable training. This session that you're in right now is not adequate preparation for prescribing this medication. Just a couple notes on the use of buprenorphine. As a partial agonist, buprenorphine generally should not be started until there are objective signs of withdrawal. This is in order to avoid precipitating withdrawal quickly. An easy way to do this is to just wait for the patient to get sniffles. Recalling our table from earlier regarding opioid withdrawal symptoms, this would be grade 1 or early symptoms. And just as an aside, if you want to more or less guarantee that a patient will never try buprenorphine again, initiate it too soon and put that patient into florid opioid withdrawal with the medication. They will definitely be reluctant to try it in the future, and this can represent actually a significant barrier to their treatment moving forward. There are actually a couple different ways to start a patient on buprenorphine. After you've got objective signs of opioid withdrawal, they can be started on a low dose and then titrated every 2 hours until symptoms of withdrawal are controlled. There are also protocols for initiating buprenorphine at home after an initial encounter with a clinician to establish a diagnosis of opioid use disorder. This requires more discussion and counseling, but it can be done by clinicians who are experienced with it. Opioid use disorder is often a relapsing condition as well, and so often patients will have experience with inducing buprenorphine, and so ask them about their past experiences and what has worked for them. Thinking specifically about patients who have opioid use disorders stemming from the use of prescription opioid medications, there are a small number of studies that have evaluated buprenorphine for these patients and found it to be effective in preventing a return to prescription opioid use. One consideration here is whether buprenorphine should be tapered or just maintained as a maintenance indefinitely. And in one trial at least, it was actually terminated early because the arm that was on the buprenorphine taper switched to maintenance or experienced a return to drug use. Now, this was a small study, but it offers some indication of what might be the best option for patients. Now, elsewhere in this series, we've talked about the role of morphine milligram equivalents and Thresholds for MMEs. It's important to know, though, that opioid dosage thresholds for caution in the treatment of pain are not applicable to opioid agonist treatment for opioid use disorder because recommended dosages of methadone and buprenorphine for opioid use disorder differ from those for pain management. In a similar vein, there's no recommended duration limit for the treatment of opioid use disorder with buprenorphine or methadone, and discontinuation of either of these is actually associated with risks for return to drug use and opioid overdose. If there is a plan to discontinue buprenorphine, it should be tapered very gradually over several months. This is an important discussion. There is some debate about the role of buprenorphine in the maintenance of opioid use disorder. The evidence seems to have landed pretty solidly on the side of continuing buprenorphine indefinitely. However, both clinicians and patients often have strong opinions about this. Is the point of treatment with buprenorphine to taper and eventually require no medication for opioid use disorder? Or is it more of a chronic condition akin to hypertension or diabetes that will likely, but not always, require lifelong treatment? There is, of course, no definitively right answer here. It depends largely on the goals of the patient and their unique circumstances. Some patients will adamantly want to get off of buprenorphine at some point. Others will be open to continuing it indefinitely. But again, the evidence for buprenorphine and methadone is pretty solid, and as a treatment for opioid use disorder has been associated with reduced overall overdose deaths and reduced all-cause deaths. Additionally, even in patients who don't necessarily have a diagnosis of opioid use disorder, if they are on opioids for chronic pain, especially at higher doses, consider transitioning to buprenorphine for pain because of its reduced risk for overdose compared with full opioid agonists. It's worth noting that methadone exists at a higher level of regulation than buprenorphine. Compared with buprenorphine, which can be prescribed by clinicians with a waiver in any setting, ongoing methadone treatment for opioid use disorder can only be provided through an opioid treatment program. Again, not all treatments for opioid use disorder are created equal, and there is better evidence supporting the use of both buprenorphine and methadone. That said, naltrexone is FDA approved for opioid use disorder, and it's worth knowing about. Naltrexone does not require a waiver and can be prescribed in any setting. It requires a minimum of 7 to 10 days free of opioids in order to avoid precipitating severe opioid withdrawal. And it is available in an extended release injectable formulation, 380 milligrams, injected IM, once every 4 weeks. Naltrexone does play a role in the treatment of opioid use disorder, but patient selection is key. This requires highly motivated patients who have already completed a withdrawal from opioids. These patients will need to adhere to monthly IM injections of the naltrexone, and it's worth knowing that oral naltrexone is rarely used except under circumstances with observed daily dosing. Similar to buprenorphine and methadone, there's no recommended duration limit for treatment of opioid use disorder with naltrexone. If naltrexone is discontinued, it can be stopped abruptly without precipitating any withdrawal symptoms. Clinicians should warn patients who discontinue naltrexone of the risk of a potentially fatal overdose if opioid is resumed, because they will have lost tolerance, and if they resume their previous opioid dosage, they could likely overdose. While medical management is the cornerstone of treatment for opioid use disorder, there are non-pharmacologic treatment options which can be used as adjuncts as well. There are various counseling options available. However, like most non-pharmacologic treatments, the patient will benefit the most if they're actively involved and engaged in the treatment. Counseling typically involves education, coping strategies, some guided imagery. There's also cognitive behavioral therapy to work on avoiding catastrophizing behaviors, again, learning some coping strategies, learning to cope with pain if that was the underlying inciting factor in the opioid use disorder evolving, and working through a lot of this deep anxiety, depression, and trauma. And bearing in mind here that with any addiction, trauma-informed care is extremely important. There are different levels of counseling. There's standard medical management. It's basic counseling recommending abstinence and participation in self-help groups. There's also intensive management with addiction, recovery, and prevention of return to drug use education, using self-help and lifestyle change recommendations, interactive exercises, and take-home assignments delivered by trained substance use treatment or mental health professionals, typically in hour-long sessions. While the evidence is limited, at least one study found that buprenorphine treatment combined with standard counseling was as effective as buprenorphine treatment combined with more intensive opioid dependence counseling. The good news here being that we can support our patients even when they don't have access to some of these more intensive or inpatient therapeutic settings. But no matter what type of counseling the patient is receiving, medical management is a must. Counseling without medical treatment using buprenorphine or methadone has not been found to be effective in treating opioid use disorder. And counseling is not required. A patient's decision to decline psychosocial treatment or the absence of available psychosocial treatment should not preclude or delay medications for opioid use disorder. Many patients will have already been in counseling and found it to not be helpful, and they'll be reluctant to return. That is okay. Proceed with medical treatment and readdress in the future. One common question that arises is how to manage postoperative pain or acute pain in a patient who's in medical treatment for opioid use disorder. There are several algorithms and flow sheets that exist for this purpose. Really, the cornerstone is preoperative planning that includes the buprenorphine prescriber setting realistic expectations with the patient in consideration of a possible regional anesthesia if at all applicable. In general, you'll continue the buprenorphine dose prior to surgery. If, following the surgery, they have adequate pain control, then no changes are needed. If not, consider adding adjunct analgesics or increasing the buprenorphine dose. If they still haven't achieved adequate pain management, initiate full mu opioid agonist treatment. That would be standard IV opioid pain medications. If at that point they still have inadequate pain control, you can consider reducing the buprenorphine dose. But again, this should be coordinated between the team managing the postoperative pain and the buprenorphine provider. Let's finish up with some considerations about when to refer a patient to an addiction medicine specialist. Well, one reason would simply be that, for whatever reason, the clinician themselves does not provide treatment for opioid use disorder. In these cases, clinicians unable to provide treatment themselves should arrange for patients with opioid use disorder to receive care from a substance use disorder treatment specialist. That could be an office-based buprenorphine or naltrexone treatment provider, and that might well include primary care providers in the area. Alternatively, you could arrange for an opioid treatment program to provide methadone or buprenorphine for patients with opioid use disorder. But even for clinicians who do provide treatment for opioid use disorder, there are instances where referral to an addiction medicine specialist is warranted. This largely involves comorbidities. Opioid use disorder can coexist with other substance use disorders. Patients who are actively using substances during opioid use disorder treatment might require greater support, potentially including this referral to addiction medicine. Make sure that you are screening not just for opioid use disorder, but other addictions such as alcohol abuse or other substances. Okay, we made it. Here are a few key takeaway points from today's session. Taper chronic opioids slowly and engage the patient in the process. There are various screening tools for opioid use disorder, but diagnosis is made using the criteria in the Diagnostic and Statistical Manual 5. Opioid use disorder is a physiologic condition and not a question of willpower, so avoid stigmatizing language around this condition. Not all medical treatment options for opioid use disorder are created equal, with buprenorphine and methadone being the preferred options. Counseling can play a role in the treatment of opioid use disorder, but it is not an essential component. And finally, refer patients to addiction medicine when they have comorbid substance use disorders, especially if they're actively using those substances during treatment.